Good morning, good afternoon, everybody. Thank you for joining us on this webinar, which the Rebuild Consortium is hosting today. My name is Sophie Witter. I am the co-research director based at Queen Margaret University in Edinburgh. And we're going to be discussing today the role of the diaspora in supporting health system resilience in fragile and shock-prone settings, which very much fits in with the Rebuild theme. So we're a consortium that's coming towards our end this April. But our focus has been on how to support the development of resilience capacities in fragile and shock-prone settings. So I'd like to introduce the team on this panel today. Can we have the next slide? Thank you. So myself and Ala, who's based at Oxford, are coordinating this particular project within Rebuild. And we're working with partners in 5 countries. So today we're going to be having a speaker from Lebanon, from the American University of Beirut, Ruham, is going to be presenting the Lebanese case study. And then we have Ghansham from Herd International in Nepal, who's going to be presenting the Nepal study. We've got Chuchu Tan from the Bonet Institute in Myanmar, will be talking to that case study. And we've got Dr. Al Sheikh, who is based in UAE, is himself a member of the diaspora, who'll be presenting the Sudan case study. And we have Halima based at the Institute for Development in Sierra Leone, who'll be presenting that one. So the format for today is to have 5 short country case studies. And then we're going to be discussing some of the cross-cutting themes and next steps. And we really look forward to your feedback, particularly around the sort of priority policy messages coming out. So just by way of brief background, this theme is not one we identified in advance, but it's one that really jumped out of us as we worked on this question of resilience capacities, because the countries we're working in are facing multiple overlapping shocks and crises. And it became very clear that the diaspora was one of the key survival strategies that they'd been using. And yet it's very much underdescribed in the health system literature. One of the interesting features is that it particularly kicks in during shocks and crises, so it's particularly useful. And many of these countries have a very substantial diaspora, and we'll be presenting some data on that in relation to the different countries. But just by way of definition, when we talk about diaspora, we're talking here about transnational communities who emigrated or dispersed from their original homeland, but remain oriented to it and preserve a group identity. So that's sort of key thing to bear in mind as we go through. Next slide, please. So the literature on diaspora has very much focused historically on remittances, which are obviously very important. So it's been seen as an economic strategy, but very much underdescribed in relation to health systems, its contribution, and particularly thinking about this question of resilience. So our question was, how do diasporas contribute to health system resilience in these settings? And underlying that, of course, is an interest in what can we do to support it. So that's the kind of underlying policy question that we're interested in. So within each of these case studies and at the global level, what we tried to unpick from existing data and from the methods that I'll just go through very briefly is what kind of contribution the diaspora makes, how they engage, and what are the things that motivate them or demotivate them, or indeed the barriers and enablers to that contribution. And that's also where some of the policy thinking will come in. Next slide. Thank you. So just to give a very high-level overview of the methodology that we've used for these, we've had 2 strands which converge. One was the global strand of research, which involved scoping review, but also key informant interviews and analysis of secondary data where it was available and relevant. And there have been some limitations around that, both globally and at country level. And then a similar set of methods used for each of the country case studies. And we're now at the stage where we've been integrating that. We'll be presenting some of the kind of cross-cutting findings today. But just to highlight that a couple of limitations, particularly around secondary data, which has been less revealing in most of the countries, some of them a little bit better than others, but not really granular enough on the role of how remittances are used, for example, to fund healthcare. But also that our interviews have had quite a strong focus on diaspora organisations. So that's something we just need to bear in mind as we hear the perspectives presented today. So we're going to move up either as we go through or at the end. So I'm going to hand straight on now to Ghanshyam to present on Nepal. Floor is yours, sir.
Thank you, Sophie. So I'm Ghanshyam Gautam from Nepal. On behalf of the study team, I'm going to present Nepal case study. Next, please. So to start with the context, Nepal government has recognized diaspora community as non-resident Nepali, which consists of Nepalese citizens residing abroad, which is the bulk of the diaspora community, as well as foreign citizens of Nepalese origin. The size of the Nepali diaspora has been growing rapidly, and it has been estimated around 7 to 10% of the population, depending on the data sources. However, in the countries, there have been persistent shocks and stressors, adding vulnerability to individuals as well as system. While from the political and economic lens, country is going through the federal restructuring, political transition is there, and the nation is going to graduate from least developed country status by this November. Next, please. In terms of engagement of diaspora, they are mainly in foreign employment, as well as for higher education, pursuing additional professional career, as well as engaging in foreign land as a legal citizen of there. Lately, health professionals have been added to the diaspora community, so it's quite increasing. Based on the latest, evidence, it seems like almost like medical graduates aiming to go abroad is increasing at the rate of 34% per annum, latest data shows. And these diaspora community engage across social, professional, economic, and political fronts, creating avenues to knowledge transfer, capital investment, and philanthropic support. When we see the figure on the right-hand side, we can already see the pattern. It's like different countries weighted in some areas, but in terms of per capita contribution, it's mainly from the advanced world. So government may need to think tailored approach while engaging with the diaspora. Next, please. So there are multiple motivating factors for the diaspora to engage, and it starts, for example, family and emotional ties, empathy during the crisis, as well as expanding their professional networks and leadership development. Same way, there are also barriers for them to engage, which includes bureaucratic procedures, unpredictable outcomes, misalignment, and trust deficit. However, motivating factors contribute to build up the social capital, such as by expanding their networks, building trust, and establishing partnership with multiple actors, which further helps to overcome the existing barriers and to amplify their contribution across financial and human front. So in terms of financing, financial capital, as Sophie mentioned before, it's mainly remittance in our context as well. It's more than 1/4 of the GDP. But at the same time, this contribution has been contributing to community resilience in terms of seeking healthcare. So in terms of human capital, it's the policy and technical support, research and academic collaboration, as well as knowledge and skill transfer. Next, please. When we look into the policy landscape, the way it is evolving, it's quite in favor of the diaspora community and government connections. So diaspora communities, on the one hand, are trying to organize themselves while the government is shaping the policy and legal framework for them to engage. And the constitution in itself recognizes diaspora community is creating special rights for them. Similarly, in terms of programmatic and institutional structure, for example, brain gain centers that was housed in the Ministry of Foreign Affairs, and latest example of Nepal Health Conclave, where health actors were connected with the diaspora community. So there is momentum going on to connect diaspora community with the country of their origin. Now, to draw some conclusions and way forward, personal connections and social networks have been the primary modes of engagement for the diaspora, while professional and institutional collaboration is still evolving. From the system lens, contribution primarily is on absorptive and adaptive capacity, while there is evolving scope for to amplify their contribution, particularly through network effects, because there are limited segment of the population who could really contribute to the system transformation. So it could be amplified through the network effect in the present digital world. In terms of strengthening the contribution of diasporas, there is a need to establish institutional entry point as well as creating a guiding framework for them to contribute. Government could also consider to facilitate institutional partnership to enhance the sustainability of the engagement and contribution rather than being it on ad hoc basis. For this purpose, diaspora as well as government could consider leveraging existing diaspora and returnee networks, professional societies, and the knowledge forums that could connect all these actors together. Similarly, it is important to recognize the contribution of a diaspora and be transparent in terms of what they have been contributing. At the end, it is quite important that to also consider health and well-being of the community, diaspora community in itself, while aiming to get benefits for the system from their end. Thank you so much. It's over from my side. Sophie, over to you.
Brilliant. Thank you very much, Ghanshyam, and thank you for sticking to time. Just to say, these countries' case studies are very rich, so we have to apologise to our speakers because they've been given quite a short time to present each, but we will be sharing more in the future in more detail. So I don't see any questions, so let's go straight on to Sierra Leone. So Halima, the floor is yours.
Hello, everyone. I am Halima Tukamara, presenting a Sierra Leone case study on behalf of the team. Next, please. Our study findings noted that in the context of Sierra Leone, the diaspora are underexploited actor in health system resilience. Geographically, they are located in countries like US, UK, including others. And during period of crisis, they usually come in. During the past Ebola and Civil War, they provide support to the health system. And in period of stability, they collaborate with local actors in the districts, like the district medical officers, and through former community leaders, like the government, especially Office of the Diaspora Affairs, and also through family members to provide support to the health system. Next, please. They usually contribute through financial means in the form of remittances. It was reported that in 2023, diaspora remitted around over 300 million USD, mainly to support their family members towards healthcare, education, including other areas. And their donation in terms of direct in-kind supports usually come in the form of medical supplies and equipment. And also, when it comes to human capital, they usually come in during health missions to provide usually to provide support to the rural communities. And during this period, they provide training and mentorship for local healthcare providers and also contribute to technical guidance, especially towards policy development. And usually they use their professional network in resource mobilization and advocacy for policy and practice and building collaboration with local actors. Next, please. Some of the enablers that we identify, like the motivating factors, because of their deep roots back home and feeling of giving back in terms of improving their health communities, this actually motivates them to raise resources in terms of using that strong professional network and also coming back to engage sometimes with international INGOs and diaspora association like the TOSHAP. Usually they come in and provide health missions in rural communities and also collaborate with government officials. And some of the enablers actually involved like their strong network and collaboration inclusive of trust and inclusive environment. And also they usually like for them to be appreciated. So the moment they are being appreciated, they have this inclusive environment and being motivated to come in and provide more support in country towards the health system. Next, please. And some of the barriers to their effective engagement usually is like being unappreciated, like doing like shipments, like shipping donated materials in country, the challenges in terms of logistical issues and like bureaucracy in taking these donated materials from the shipping companies kind of like demotivates them. And also when it comes to lack of comprehensive engagement for them and also policy regulatory mechanisms for them actually to navigate the system is also challenging for them. So these are all barriers towards effective engagement when it comes to diaspora coming in to support the health system. Some of the unintended consequences that we identify, most of the time, these donated materials are not aligned with the government of Sierra Leone priorities. And sometimes they do donate materials which have very short shelf life. And usually, their support usually lead to dependency and sustainability challenges. Next, please. So to conclude, diaspora contribution usually improve service delivery and improve access in the rural communities and also reduce equity when it comes to service delivery. And also for some of the recommendations that were actually noted is that there is a need for government of Sierra Leone to develop a national diaspora engagement framework that focus on sustainability and also a building up on feedback mechanism, providing feedback to this diaspora, and also that is tailored toward needs-based prioritization. Thank you. Over.
Thank you very much, Halima. We've got no questions on that. So please do feel free to jump in, audience, if there's anything coming up. No, sorry, we've just got one. We've got a question. For Sierra Leone, did the diaspora mention where they look for information to determine what is needed before they donate? Just a quick question to you, Halima.
Yeah, so in Sierra Leone, the diaspora, in terms of communication feedback, there is no forum for them to provide in terms of like where they get information. There is this absence of this communication feedback mechanism.
Okay, so that could be an area for, I guess, to look at in terms of policy messaging. Right, thank you very much. Again, there will be time at the end for more discussion, but we will go then straight on to Lebanon. So Ruham, over to you.
Okay, hello everybody. Wait, am I okay?
We can hear you fine, yeah, go ahead.
So I am Ruham Yamut. I'm presenting on the Lebanon case study on behalf of all the team involved in this case study. So let us start. As you may know, Lebanon has been facing a series of crises back to back, including a severe economic collapse starting in 2019, which disrupted both the private and the public health financing mechanisms, and a series of shocks like the Beirut blast and the generalized war last year that have driven the country into a recurrent humanitarian situation. All this pushed large parts of this population, or maybe all the population, into vulnerability. In this context, the diaspora became the last resort for the country. Effectively, Lebanon has a large and highly engaged diaspora that are all employed in business and professionals, and estimated to be twice the size of the domestic population, and it contributes around 1/3 of the national GDP. Diaspora has always supported the homeland. But the scale of disruption means that diaspora involvement is no longer complementary. It has become a critical survival mechanism, especially that the state's response is limited, not say completely absent. Next, please. We defined several channels of diaspora contribution, which we represent on this diagram. We start with the individual level donations, or what we call remittances, are channeled in priority to family members to help them maintain access to healthcare, and indirectly, those remittances protect health facilities from bankruptcy through maintaining their clientele. Individuals also donate to communitarian networks, either to local communities in their villages or towns of origin, or to religious faith-based organizations. Those contributions flow through local and religious channels, mobilizing both financial donation and pro bono professional contributions. These strengthen community-level coping mechanism along with social and religious lines. Although individual contributions mainly can be attributed to absorptive capacity because they are helping in maintaining the health system functioning. During the consecutive humanitarian emergencies, we observed informal diaspora grassroots collectives in action. These groups advocate and fundraise for Lebanon and directly help in operating emergency relief through flexible and innovative arrangements. Given the fact that diaspora grassroots collectives bring in new resources and adapt the processes, this and collaborative arrangement, we can attribute their contribution to adaptive capacities. Finally, diaspora medical associations are an emerging channel. Their contributions are less financial and more focused on training, policy dialogue, technical expertise, and knowledge sharing. They collaborate with officials and non-governmental secular organizations that operate at the national level. This channel holds a transformative potential because it has accumulated expertise and it is close to domestic national decision makers. Next, please. For individual contributions, motivations are trust, family and social ties, religious duty, including zakat in Islamic organizations, and personal choices. Grassroots collectives are motivated by a sense of solidarity and by a widespread outrage with the state's inertia, unfortunately. Their rapid and adaptive action is enabled by social media and innovative pathways in relief provision. Medical associations are motivated to strengthen the domestic health system as it appears in their URL websites. However, motivation is not enough. Communitarian contributions, for example, follow personal choices rather than real population needs, and they favor certain communities rather than the entire population, which logically maintains inequities in the country. Grassroots action lack coordination, leading to fragmentation and systemic incoherence. Their reliance on voluntarism and emotional funding exposes them to fatigue and short-term action. Medical associations focus more on technological innovation in medicine than on advocating for health equity among decision makers. And for all channels, contributions are all dependent on the economic conditions of the host countries. All this shows us that while the diaspora contribution is undoubtedly necessary for system survival now, current modes cannot be indefinitely reliable, in addition to them sustaining the health system as it is, rather than transforming it into a more equitable one. Consequently, strengthening the transformative potential of diaspora contributions requires a move beyond charity and individual decisions toward pooled resources and more equitable distribution aligned with the national health strategies. Thank you. Back to you, Sophie.
Fantastic. Thank you very much, Ruham. I'm not seeing any questions, so I think we will move straight on to Myanmar. So Chichu, over to you.
Hello, everyone. I'm Chichu from Myanmar, and I will be presenting this Myanmar case study on behalf of the study team. Next slide, please. Looking at the diaspora of Myanmar, first I wanted to be talking about the context Currently, we have two governments, one outside of the country called the National Unity Government, NUG, and one inside government, which is mainly ruled by the military. And we have 135 ethnic minorities. So the country is a little bit different to other countries that we are in the middle of a major crisis and it's growing. But the growing number of diaspora due to conflict and insecurity is estimated at 4 to 5 million diaspora around the world. 421 has made many of the Myanmar people as diaspora moving from country due to political reason. The main reason for migration are mainly economic, and mostly in the previous terms before 2021, many people moved for economic migration to Thailand, Singapore, Malaysia in the Southeast Asia region. And for academic migration, many of the medical diaspora mainly moved to UK, US, Australia, and Singapore. So I would like to describe the diaspora as first generation diaspora who are older and more stabilized in host countries. And then the second generation diaspora moving towards economic development and better opportunities have been in before 2021. But recent generations after the 2021 are of the diaspora faces more hardship. They became more younger and it's really hard for them to return into the country. Next slide, please. So key forms of diaspora contributions are as of other countries. For the more established diaspora who has been out of the country for so long, usually give back technical assistance, especially for medical diaspora before 2021 by many of the global diaspora community around the world by Myanmar medical associations related diaspora on technical return or technical contribution towards Myanmar. And there is, of course, remittance given towards the country. But to be frank, even before 2021, according to the study findings, advocacy on health system building was very little. But after 2021, civil disobedience movement, which is mainly led by the medical community, are recent diaspora with much understanding of the recent context of the country and how to maneuver between internally displaced person and how to give assistance or how to give humanitarian giving back into the country. So along with the medical diaspora, when we speak about diaspora contribution, because of the conflict, it is mainly given as humanitarian contributions, and health cannot be defined differently from the humanitarian assistance. So many of the medical diaspora around the world, especially for Myanmar, are doing a lot of advocacy to rebuild our country. And there are different types of fundraising efforts, like not only doing special fundraising events such as large concerts and large contributions by selling goods in other countries and sending back humanitarian assistance. There is a lot of technical contribution to the internal displaced person using social telemedication methods such as Telejama, Telehealth Myanmar channels, really giving health education, and not only health education, sometimes even medical assistance such as mental health services through a contribution by diaspora outside going into the internally displaced population. Next slide, please. So when we look at the main outcomes and impacts of diaspora contribution, we can talk about service delivery in terms of crisis response through telemedication and online training of health staff on the ground. There is a lot of service delivery being given back to the internally displaced population, which is in crisis. And another thing is human resource development, because many of the capacity building and professional development programs are being done in crisis places where a lot of the internal displaced persons are there. So to be frank, in the whole country, there are over 6 million internally displaced population, and these diaspora contributions contribute a lot to the human resource development. And there's a lot of digital health innovation mechanism being going on, because on ground health innovations are really hard at this point in time. And for infrastructure development, there's a lot of establishment of secondary care centers and primary health care clinics in conflict-affected areas supported by diaspora. And for health financing, the diaspora contribution is often collaborated with multilateral donor contributions, and direct diaspora contribution mechanisms are being done through these channels. So when we look at the two government, we know diaspora mainly support is going on to the Ministry of Health National Unity Government in collaboration with the global health diaspora networks around the world, which has contributed enormous contribution to the health. Next slide, please. But it is not always, next slide. But the main factor that really affects the diaspora's contribution is, for the diaspora, security and legal issues are quite large after the 2021 crisis, because many of the medical professionals who are away from country for security and legal issues, this quote talks about them. I used to be somebody, and now I know that I am not who I used to be. I am in a new place, adapting and trying to live my daily life. There are so many challenges I face as an individual, but if I can contribute with my professional skill, I feel much useful, meaning that although they are contributing their technical expertise, they do face security and legal matters in the countries which are being hosting some of the diaspora for Myanmar. There are a lot of mistrust and power dynamics going on with the diaspora community, because there is two government and there is a mistrust between a lot of the medical professionals in providing diaspora support to internally displaced persons. For the human resource development, it is tricky because we are contributing to the human resource development in many of the internally displaced persons, but it is not really connected to the military government at all. So when we talk about human resource development, it is for the equity issue. I think we are really dealing with crisis situation, and only emergency planning and health system building resources are really towards the internally conflict and internally displaced population rather than to the whole country. So when the country was stable, the diaspora contribution was directed towards the normal government. But at this time, there is a lot of fragmented structures, and diaspora contribution is enormous, and diaspora contribution has been a real force to develop and restoration of the nation. Thank you. Sophie, over.
Great, thank you very much. So there are some interesting questions coming in, but I think they're more general rather than being specific to Myanmar. So I think we'll hold them and come back to them at the end. I mean, some interesting new themes obviously coming out of that presentation around the political role of the diaspora, and also some of the way in which the health workforce has engaged. And I think we're going to pick those up in the next presentation on Sudan. So over to you, Dr. El-Sheikh.
Thank you so much, Sophie. This is El-Sheikh Badr. I will be presenting on behalf of the Sudan group, the case study on Sudan. Next. So as a matter of context, Sudan, once the largest country in Africa, has undergone different turning points, including unrest historically, and currently the country is in crisis, in security crisis, and there is an ongoing war with implications on population movement, with refugees and internally displaced people and disruption of health services. So the current situation of Sudan is a humanitarian situation, and at the backdrop of this situation, we will be discussing around diaspora contribution next. And this is just a trajectory of the Sudan shock landscape with long-standing civil war since the 1980s, or even starting before, and then the secession of the South Sudan in 2011, which has been part of Sudan, and then lots of political and security turmoil with the eruption of the current security situation in 2023. And the country is now in a complex humanitarian situation, as I mentioned. Next. So the health worker migration landscape, and this is actually as a background to diaspora contribution. Health worker migration has traditionally been well established in Sudan since 1960s. And in 2005, we estimated that Sudan has almost 60% of its physician workforce practicing outside the country, going mainly to Western destinations, but also increasingly to Gulf states within the region. And after the war, there was a massive exodus of health professionals. We have historically established diaspora engagement in Sudan, providing different kinds of support to the health system of the country. But this has been enhanced recently with the crisis situation. Next. So it includes the financial capital, the social capital, and the technical capital. In terms of the financial capital, the remittances, as in other countries, is an outstanding source of contribution, and the Sudanese medical diaspora, as part of the general Sudanese diaspora, has been contributing immensely in terms of residents supporting families and communities in Sudan. Unfortunately, this is not quantified because of using non-formal transfer channels of money mainly. That's why it's a challenge. But everybody in Sudan knows that this is a huge contribution. Next. And in terms of the human capital, this has been very much demonstrated in the contribution of the individual Sudanese diaspora and also diaspora associations to health services provision inside the country in form of missions, doing surgeries and medical services, but not only that, also supporting the training of the next generation in medical schools, health proficiency schools, and even at the postgraduate level and CPD level as well. Next. And there is a quite evident social capital of the Sudanese diaspora in terms of the collective move of the diaspora community to support local communities in Sudan, including examples that were found in this study of community networks, community engagement, and community mobilization through diaspora contribution. Next. The Sudanese diaspora is engaged in many different forms, including individual diaspora engagement at the community level and then at the institutional level, but also diaspora organizations linking directly to the government of Sudan, represented by the Ministry of Health and other organizations, and linking also to the country through UN agencies and other international organizations, or directly working with communities. Next. In fact, this is an important slide as a finding of this study that the diaspora contribution in Sudan is witnessing transformation. So the configuration and the contribution is going from ad hoc missions to in-country institutions. So we are more seeing diaspora networks and associations establishing factions, committees, and even units and offices inside Sudan. So it's becoming more structured. The second observed trend is that diaspora is contributing to major fundraising initiatives in destination countries, and this has been recently bringing substantial financial contribution to the health system in Sudan. The third observation is a deeper day-to-day collaboration with Sudanese-based professionals, unlike what we saw in the past, where there were some tensions. Currently, we are seeing more and more synergy between the professionals inside Sudan and the diaspora group. There is also stronger and more practical entry points with government. Diaspora is more and more now streamlining their contribution through governmental institutions and working effectively with local partners. And they are representing a unique bridge to communities and building trust networks. We have examples of diaspora working closely with local communities in terms of health promotion, prevention, and combat of communicable diseases. And then also we are seeing more coordinated and systems-oriented impact with diaspora now engaging in areas related to health policy, health system research, and advising on health system development. Next. So this is a final slide discussing around some challenges and prospects. Challenges are more or less similar to what is mentioned by other country case studies, and these challenges can be classified as challenges in Sudan related to the institutional framework for diaspora contribution, and challenges within the destination countries related to enabling and disabling factors the diaspora face in those countries. And here we have the trajectory of comparing the Gulf states to the Western countries. And this is a very interesting comparison in this response and in this respect. And then we have diaspora-related factors where there are some issues like the political divisions and some of the tensions between the diaspora group, but these are recently being, more and more overcome in the context of the crisis in Sudan. And as a matter of recommendation, we see promising prospects for diaspora contribution in Sudan with diaspora institutionalized initiatives being now more and more encouraged and demonstrated, and also the readiness of the Sudanese health system being observed now from the leaders of the health system in Sudan, committing now to embrace a structured approach to streamline diaspora contribution and engagement. Thank you so much.
Right, thank you, Dr. Al-Sheikh. I think there are a couple of questions that have come up from the audience that are specific to yours. So just to put them to you quickly, one of them was around the whether there are statistics on migration by other health groups, so not just the doctors, but also nurses and midwives, for example. And I think the second question was around whether the diaspora engagement varied by regions within Sudan, whether it was stronger for certain regions within the country. So both questions, I think, from Samantha.
Thank you for those good questions. In terms of engagement, the diaspora used to engage mostly in Sudan at the national level, contributing at the national level, but extending that contribution to local communities as well. So there is no clear differentiation that there are certain regions which are more focused, but it's a national contribution radiating to different parts of the country. And what's unique about the contribution of the Sudanese diaspora is that they are addressing the crisis at the grassroots, or also working in many conflict-affected settings locally. In terms of the second question on the other health professionals, traditionally, health worker migration in Sudan has been physician-dominated historically due to structural reasons in the country, and that reasons relating to the type and level of health professions education. But increasingly, over the 1990s and the period after, we are seeing more of engagement of other health professions, including nurses, pharmacists, and allied health professionals, technicians, and other health professionals. So these is a recent observation, and mostly this trend of migration of other health professionals is mostly local in the region to the Gulf states and some places in Africa around Sudan. But the migration has traditionally been physician-led and mainly following a path to Western countries, in particular the United Kingdom and the Republic of Ireland, and not to forget also the Gulf states. Thank you.
Great, thank you. There's some other questions, I think they're more general, so we'll hang on to them for the moment. So it's over to you, Ella, just to try and look at what is universal, what is specific across these really interesting, wide-ranging cases.
Thank you, Sophie.
Not an easy job. It's but crucial.
Not easy, definitely not easy. But yes, thank you, Sophie. And I think the main idea we had after looking at the individual case studies is to sort of zoom out and then compare across the 5 country case studies because they have different contexts, and then also juxtapose that comparison to global evidence we have from other fragile and shock-prone settings, and sort of then highlight what is universal across all fragile and shock-prone settings, if we can make that judgment, and then what is context specific. Now, I'll present that, but I just want to preface that these are super high level, and we will have detailed information coming out in publications and other dissemination formats. Now, in terms of context, all countries we've looked at so far, and also fragile settings, are crisis prone, and crisis has emerged as an activation trigger for diaspora engagement. There are 2 arguments for this. A, because of the solidarity argument, so diaspora step in to be in solidarity with communities when crisis hits. But the other argument, especially for conflict-affected states and also states where legitimacy of the government is contested, is that crisis allows diaspora to sort of like overcome those grievances towards the state and then work together for the common purpose. So it sort of like unites diaspora and communities and the state towards one common enemy. Now, diaspora, as we prefaced in the beginning of the presentation, step in, so they serve as surge capacity when state systems are overwhelmed or unable to meet demand. Health and humanitarian response dominate in crisis, but what we're seeing consistent across contexts is that engagement drops immediately when the crisis sort of like relapses or recovers, and post-crisis contributions or support to health system resilience is quite limited, and that we're thinking is contingent on the capacity of the context to sustain engagement with diaspora. Now, the third universal feature is that diaspora is a highly heterogeneous group. It is very important to be mindful of the size, the skill composition, the generation of diaspora that we're speaking about within a diaspora population, but also other subtle differences such as the ethnic identities, political identities, migration histories, class constructs within diaspora that affect how they engage, who they engage, and how much collective network power they have. What is also universal is that they maintain strong emotional ties, and that is a key motivator for their engagement. Professional diaspora, which is mainly health professionals, dominate, especially for human and social capital contributions. But with financial contributions like remittances, they're universal across all different professional groups of diaspora and all different class groups of diaspora. Now, when we ask the question, what is context specific, it is important, first of all, to reflect on the contexts of the countries that we've looked at so far. The order of the presentation was not random. So we started with Nepal, which is sort of a post-conflict developing state, but extremely climate vulnerable and crisis prone. And then we also had Sierra Leone, which is post-conflict developing, then Lebanon, which is currently in a political economic crisis, but also experiences large-scale population movements because of regional conflict as well. Now, Myanmar and Sudan are one of the most extremely fragile in our case studies. Both have interstate conflict and political instability, and both are in humanitarian crisis. And that really shapes how diaspora engage and the form and scale of diaspora contributions. Now, broad themes we're seeing is that when it's natural disasters, diaspora contributions are sort of immediate and focused on relief efforts and very short term. But when it's conflict, we're seeing more sustained engagement and a focus on capacity building of local actors, so a localization of diaspora contributions. And finally, we're also seeing that with conflict, there is more regionalized concentration depending on where areas of the country where conflict is more intense. Another key feature we're seeing is that with political crisis, which is we're thinking dynamic political opportunities, revolutions, so Sudan and Syria, these are sort of like open avenues for added diaspora engagement, as we've seen both in the Sudan revolution and the Syria case study. Now, the country context itself affects diaspora. So like we said, Sudan and Myanmar are conflict affected. What this means is that there's higher diaspora intergroup divisions along ethnic and political identities, and that erodes social capital. And we will come to why this is quite important when we look at diaspora contributions. A third point I wanted to make on this slide is that the host country, so the country where diaspora reside, is also very key. So despite some countries in our data set having large Gulf-based diaspora, their contributions are sort of smaller in size and scale when we compare them to diaspora based in the US, in the UK, and in the West. And these are very important in terms of host country factors and how they enable or constrain diaspora. In terms of diaspora contributions, they're largely universal. I am not going to go into the exact contributions, but we have a publication that's going to be out soon that details that. But multiple diaspora capital, drawing on financial, social, and human capital, contribute to multiple resilience capacities. And we've put that in a sort of like a circle on the right, so we can see resilience capacities such as availability of physical resources, financial resources, human resources, but also diaspora contributing to networks and collaboration, to information systems, to adaptive governance in crisis and post-crisis, to innovation and flexibility. And these are and then to community capacities and resilience capabilities. And all these are really key in supporting the resilience of health systems in FSP settings. Now, social capital is the most pivotal contribution. Why is that so? It's because it enables all other capital contributions. So it is sort of like foundational for remittance to flow, foundational for other financial and in-kind donations to flow, foundational for human capital contributions as well. And this becomes important because for conflict-affected communities, by default, as we know from political sciences literature, they have eroded social capital because of the protracted effect of conflict on the social fabric of these communities. And so this becomes a really important point to contend with, because social capital enables diaspora contributions, but then it's eroded as well in conflict settings, and we need to think about that in terms of policy and practice. Finally, what is also very common is remittances by far are the most common contribution, and they transcend diaspora size, scale, and skill composition. So whether you are a low-skilled migrant or you are, a doctor working at a really big hospital in a country in the West, you're still remitting. The size and scale, of course, differs. So remittances are higher from Western countries than Gulf, but it's also very context dependent. We can't make very generalized observations here. Another really key contribution we're seeing is that collective remittances, and these are exemplified in zakat, Islamic zakat. As people may know, this is a wealth-based tax that Islamic communities practice. And these have been really key in sort of like collective remittances. So diaspora communities would collect this zakat and then transfer it to communities in their home countries, whether it's in Sudan, Syria, Lebanon, so countries with significant religious populations. And the reason we mention this is that although it's quite understudied, UNDP and World Bank estimate that Islamic zakat ranges between 200 billion to 1 trillion per annum. And so it is a really large source of financial flows that either flows through collective remittances to communities or through philanthropic efforts, and is worth paying attention to. So we then ask the question, how do diaspora engage? What is universal and what is context specific? What is universal is that predominantly across all case studies, diaspora engagement is diaspora-led and informal. Informal meaning they utilize personal networks or professional networks that are trust-based. And this brings us to the point of network power. The stronger the capacity of the diaspora, so the stronger the network power of diaspora, the more they are able to contribute to the health systems in their countries of origin. And so this is a really key enabler overall. But engagement is not static. It is dynamic and continuously shaped by several factors, which are motivators, push factors from diaspora, barriers, and we're going to look at them in a little bit, but also enabling conditions that support diaspora engagement, and then influencing factors that shape the size and the scale and the sustainability of diaspora engagement. So these are really important to think about, especially as we've said at the beginning of the presentation, when we want to look at policy and practice implications. Now, what is context specific? For stronger states within the fragility spectrum, so we're thinking Nepal in this case, diaspora engagement is state recognized and sort of like state driven in a way through the facilitation of policy and institutional landscapes. But because of the weak institutions and the bureaucracy, that sort of like hampers the capacity of the state to absorb diaspora contributions. Now in Lebanon, we're seeing predominance of grassroots engagement, so it's sort of like state bypass, and the challenge with that is sectarian channels will then predominate. With Myanmar, again, state bypass with parallel structures predominating. And this is also because of the political landscape. Like we said, the diaspora-state relations shape engagement models as well. And they're very important to contend with as we're thinking of long-term engagement. With Sierra Leone, we're also seeing local actor engagement predominate, either through supporting NGOs or district partnerships. So the state bypass in this case is also because of the weak institutions. Diaspora do have challenge with engaging with government institutions, either because there's no structured pathways or because of the weak regulatory capacity, which then leads to corruption concerns and mistrust coming up. With Sudan, we're seeing multi-actor engagement models, and this is largely because of the crisis setting, which then prompted more diaspora engagement, more localization of diaspora support, but also now as we're looking at some recovery efforts in the context, we're seeing more diaspora, government, and INGO collaboration models in the context. Now, very quickly, I'm conscious of time, is motivators. We looked at motivators in literature and contrasted that with the case studies, and we've mapped them into intrinsic motivators for diaspora, but also extrinsic motivators. And these extrinsic are where we could sort of think about when we're thinking about engaging diaspora, how do we ensure that the diaspora are also gaining from this these interactions to support their home countries. Now, barriers across all the contexts have been largely structural, meaning individual barriers such as personal circumstances, professional constraints, and so on experienced by diaspora are real, but they're not the overwhelming the overwhelming limitation to diaspora contributions. What is the overwhelming limitation to diaspora contributions are structural barriers, whether at organizational level, so we're seeing across literature and in the case studies, weak institutional capacity, coordination challenges, low receptiveness of institutions in the home countries, intergroup divisions between diaspora that prevent collective action, and then local resistance and power dynamics where, local actors are suspicious of diaspora intentions, but also there's this challenge of how do you manage the dynamic of an external coming in and local mistrust rising towards that. We're also seeing larger structural barriers such as broadly lack of recognition of diaspora as essential actors, whether in formal humanitarian systems or whether they're integrated in coordination mechanisms, but also political and legal barriers. So sanctions preventing financial contributions in a large way or sort of supporting informal ways, and then political instability and insecurity amidst other barriers. In terms of how diaspora support resilience capacities, I'm nearing the end of my presentation, but diaspora engagement so far across the settings that we've looked at strongly strengthens absorptive capacity, meaning diaspora contributions support continuity of service and crisis response in that initial phase of crisis. They also support adaptation, and that is either through knowledge exchange or translation of whether it's innovation or skills transfer. So this really helps the system adapt in the face of crisis. And finally, the transformative effect. So how can diaspora really contribute to health system transformation in ways where health systems emerge better and stronger from crisis? This remains limited across cases and seems to be contingent on the status of the health system and its configuration, but also on the capacity of the actors to sustain engagement beyond crisis. Now, are diaspora contributions fully, positive? No, there's some risks and unintended consequences we've come to find in literature and also in our case studies that we need to contend with. And an essential question is, are diaspora contributions in a way increasing fragmentation in national health systems? Are there concerns about private sector expansion and what that means for universal healthcare? What about vertical programs that diaspora lead? What about diaspora initiatives that sort of support immigration and contribute to the deep challenge of brain drain and health workforce migration in fragile settings? And also other concerns about sustainability, but crowding out effective remittances as well. So do the higher inflows of remittances encourage less public expenditure and public focus on social protection programs? These are all risks we're thinking of and we think should be appreciated. Now, to summarize from my presentation, key messages: what is universal across fragile and shock-prone settings can be leveraged. And what is context-specific needs to be tailored. And finally, effective diaspora engagement is essential. So it is absolutely foundational for truly leveraging diaspora capital contributions to health system resilience capacities. But this engagement isn't static. It is dynamic and continuously shaped by the interaction of motivating factors, impeding factors, enabling and influencing conditions. That is it. Thank you, Sophie.
Thank you. A lot to cover. And some interesting questions coming in. So I think we're not going to spend very long on this last section because we are still thinking about this. As we said, we're doing the kind of cross analysis and write up at the moment. But maybe just to show the next slide, the question here is sort of what does this mean in terms of what should be done? And there's quite a few sort of prompts and suggestions in the chat as well that we can pick up on. But I think we're so interested in your ideas, but just to highlight that there are risks in trying to formalize, but not least because so much of this contribution is based on networks, on trust, on kind of informal and personal relationships. But it is very, very varied across the context. So I guess the kind of very broad brush conclusion is that we don't want to suggest some kind of model that would fit across all of them, but really the countries, even in our group, face very different context. So more information sharing, approaches to better distribution potentially, or maximizing effectiveness, but really without kind of killing that voluntarism, which is at the base of the diaspora's very sizable contribution, as highlighted by all these case studies. And just to pick up on one of the research areas, I think it's clear that there is more work to be done, and particularly thinking about the intervention side. And quite a lot of the questions were about that. They're about what can we do, what's working, what models are being tried to kind of leverage this. And the answer is there's not a huge literature on that in relation to the health sector. And so I think this is an area where we'd welcome your thoughts and also, just a continued effort by the community as a whole to kind of document and understand and develop those models. So we'd like to go straight into a kind of question and answer at this stage. And I think panelists, if you can put your cameras back on and then please just indicate if there are questions that you're interested in picking up on. But maybe I'll just start with one, which was around host countries. So are there any models that we've come across in the literature or in the case studies of where host countries have facilitated the diaspora to be more effective in supporting their home countries? That's one question. And the second question, I think that was from Goran. The second question from Nigel was about, do governments have an overview of the diaspora's work and its contributions? And I guess the question is, if not, could that be done in a way that isn't disruptive of the kind of trust-based network? So any thoughts on those two, just for starters? Just jump in if you want to speak to them.
Okay, I have from Lebanon examples of host countries supporting diaspora. This is during after the Beirut blast, after the port explosion. Many diaspora grassroots collectives fundraised and advocated in their host countries. And from those, we received a lot of millions. I don't remember how much, 8 or 9 million from the Brazilian government because of diaspora advocating for Lebanon.
Okay, great.
Yeah,
Any other examples would be interesting, Ella.
yeah, if I can come in as well. Now, these are really good questions, and I think looking at the global literature, we did see some factors that support diaspora from the host country side. So primarily recognition. For example, during the Ebola crisis, the UK in its Ebola task force recognized Sierra Leone diaspora and involved them. So those avenues of involvement were key. But secondly, the funding landscape as well. So the availability of funding for diaspora associations based in host countries is key for their work. The third point is regulatory landscape. Now, the key contrast we're seeing between Gulf states and the Western states is how much does the regulatory environment allow mobilization of diaspora, and whether that's for advocacy or for contributions and support, and how much does it limit? So things like sanctions or remittance taxes being imposed are things that would sort of like prevent. These are the broad findings we're seeing. Now, on the second question from Nigel on do countries have an overview of diaspora activities? Not that we know of. So neither do countries have a good statistic of their diaspora. So diaspora mapping exercises are being encouraged and done by IOM and governments, but there's not yet that sort of like central database where you can say these are diaspora and these are the activities they're doing. Now, because that doesn't exist, this is why we're seeing a lot of duplication, but also competition between diaspora groups because priorities are being focused on whilst others are not being attended to.
Yeah, thank you. I think there was also a comment from Zoran about is there a risk of corruption if we formalize diaspora contributions? And maybe related but slightly different from Elena about are there any good examples of governments maximizing the diaspora? So taking specific measures, I suppose, to maximize the diaspora contribution. I mean, maybe on the second one, Ghanshyam, there were some interesting examples from Nepal, if you want to mention maybe one or two of those.
Yes. I mean, Nepal government, particularly in terms of engaging diaspora, they have been going through the various legal frameworks, and it's difficult to really estimate the size of the diaspora that are abroad. But in terms of, I mean, the government is really tracking in terms of the absentee population, like migrant population. That's through the legal, they have to go through some legal processes like getting approval, all these things. That's why who are going abroad, that's traceable. But who are staying abroad, it's quite difficult to estimate. But government initiated like brain gain center where they encourage diaspora community to connect and come with the I mean you be registered with the government so that they could connect them with the right entities or sectors. So in that endeavor there were quite like professional people, those in the professional jobs were connected, but it has not functioning the way it was intended, but the initiation is towards that direction. In terms of like a correction, I mean, corruption, all these issues, I mean, we also got some sense like it's people from the diaspora community that when government started to really kind of regulate the diasporas or external contribution to the system, then people were reluctant to contribute. So, like a government created a fund for diaspora to contribute during the COVID time, and people were reporting, okay, if I don't get the space to contribute where uh, I want to, then I have less interest to contribute. So that kind of concerns was also coming. That is somehow also linked to transparency and governance corruption issues. So I think regulating the diaspora contribution is probably not the right way to move forward, but creating a framework for them to engage and contribute in a desirable avenues. Thank you, Sophie.
Great, thank you very much. There's also some questions around the phasing. So there's a sense that this contribution is quite strong during crisis periods. And there were a couple of questions which were around, how do you then leverage or encourage the contributions to continue post-crisis? I think that was from Samantha. So I don't know if anyone has any thoughts on that, or maybe Ella, from the general literature, we've got a bit more overview of the different stages of crisis and how diaspora waxes and wanes, or could be encouraged to not wane too much post-conflict. Or anyone else, over to you.
Yeah, no, I think so I'm going to share my reflections on that, but I'm also conscious Dr. Sheikh has his hand up.
Apologies, I'm not seeing all the speakers, so apologies if I've been neglecting him.
No, that's completely fine. Yeah. I think it's really hard to answer that question because, like I said, what we're seeing is there's a complete drop in diaspora engagement post-crisis. I assume that's attributed to the weak institutions and their capacity to sustain that engagement. It's also come up in several of the interviews. And I think this is an area we can continuously explore, which is making that link between crisis and then recovery and development. And then again, let's bear in mind that the different country contexts are quite different. So even in relatively stable, fragile settings like Nepal and Sierra Leone, diaspora might not choose to engage directly with state institutions because of, again, mistrust around different avenues, corruption and so on. And so that lack of engagement isn't just attributed to weak state institutions, but also about diaspora perception of state institutions, diaspora perception of state legitimacy, and overall diaspora-state relations. And we're seeing more different models. So diaspora engagement with international organizations for long-term programs. So IOM has historically and currently led structured engagement programs where they try to siphon diaspora technical expertise to support development long-term, but it's also very small scale. So we can't really draw conclusions. But this is an area of research that we can keep exploring.
Thank you very much, Dr. El-Sheikh.
Yes, just a quick response on 2 points. The point related to the formalization of diaspora engagement. I think I would say from the experience in Sudan and the Sudan case study and even looking globally, I think this should be formalization is needed, but it should be approached carefully to allow, as Ghanshan was saying, to provide like a framework which is encouraging and not restricting. And I think the diaspora themselves, in many studies, I have seen diaspora are referring to lack of national framework for engagement as a limitation. That's why they wanted their governments to really intervene and facilitate the contribution. But at the same time, this facilitation should be done in a broader way to enable diaspora to contribute. In our case study in Sudan, there was a unique finding where some diaspora are really providing their support conditioned to be delivered to certain local communities. So this is my first point. The second point is the engagement of diaspora in the crisis situation is more evident due to clear reasons related to humanitarian response and emotions and all these things. But I think in our case study in Sudan, we also had findings indicating that the joint planning and the engagement of diaspora from the side of the government has triggered diaspora to commit and to take steps towards engagement in developmental and long-term phases. And we have an example of a Sudanese Diaspora Association creating an institute or entity on health system strengthening as a response to the initiative from the Sudanese government. Thank you.
Yeah, very interesting example. Thank you very much. I can see, Ruham, you've got your hand up, and I just want to put one question to you that came out of the chat, which was around why you think the diaspora medical organizations have got such a biomedical focus. And actually related to that, somebody else put in the chat about the fact that other groups like public health officers have had a big contribution in diaspora organizations. So there's a bit of an inter-medical debate on the chat. But over to you.
Okay. From what I knew, because I did some research on this matter, it seems that it is the case in all medical collectives, okay, in order of physicians everywhere. Medical doctors are very much focused on biomedical, which is understandable, okay, because it is their job. And very few of medical doctors have really this public health side and health system overview. This is why it is not a bad intention. It is how they understand strengthening. For them, strengthening is bringing telemedicine. It is bringing AI in medicine. For them, this is strengthening health system. They don't think in terms of equity, of needs-based, of social justice. They are very much focused around the biomedical thing. This is what I found in literature. I don't know if there are other explanations. I wanted to intervene also in the topic that was before. So the diaspora usually use the same path and the same channels that are in place in the domestic. They don't bring new. It is very rare when they bring new. And even if they wanted, they are like absorbed by whatever is being done in the country. For example, in Lebanon, after crisis, it did not. There is no fluctuation really in the amount of contribution in the crisis and outside crisis, if we account for the inflation, okay, because all the GDP went down. This is why diaspora appeared to be more, but in absolute numbers, it is the same during the crisis and outside the crisis.
Okay.
This shows us something that diaspora contribution changes in nature, in scope during the crisis, and whenever the crisis ends, they return to their previous ways of contributing. I think this can be an explanation.
Great. Thank you very much. So just to say, there's some useful resources shared in the chat, some materials from Nigeria, also some databases which have evidence on remittances and so on. So hopefully everyone can access those. And obviously we will be sharing the slide set as well afterwards, just to reassure some of the people who've joined. There was one question from Muna about whether diaspora has been able to reach areas that other humanitarian actors have not managed to reach. I'm interested what the panelists think on that. And Chuchu, if you're still there, maybe you can pick up on that, as we've not pulled you into the discussion yet. So what do you think? My instinct was yes, but I'm not.
Yes. I think I would say yes, because in our context, because it is very much trust related, and really interconnectedness of the health diaspora on ground and on diaspora outside. Because there is a very thin margin when you become a diaspora just after a political crisis, but you still have close connections to the ground where the real crisis and real conflict is happening. So I think in that case, diaspora are really connected to some of the difficult areas where normal humanitarian persons or international organization cannot be reached. So I think diaspora contribution has really showed in our case that diaspora support has been really essential and instrumental in reaching to the most conflict areas where international organizations cannot be reached because of trust and also understanding of the context. Yes.
Great. Thank you very much. There may be others who want to jump in, but I just want to put this question to the group as well. This is from Samantha. From your finding, did you identify a wider diaspora coordination network that links professional networks for more efficient and synergistic actions? Is this something that's accessible? Any thoughts on that? I'm not quite sure whether that question is about a country-based network or a kind of cross-country network, but either thoughts on either would be interesting.
Yeah, I can comment on that one, Sophie, if possible. I think just first to support what Chuchu just shared, diaspora are really able to reach, situations or regions in conflict where humanitarian actors are not able to, because they work localized. So the localization agenda that humanitarian actors are always speaking about, diaspora actually walk the talk when it comes to that, and they, are in deep connection with local actors, understand local needs, and transfer resources unconditionally. So if you're a local community member, you're not filling in a grant proposal for a project and then waiting 6 to 10 months for UNICEF to approve and send in the money, but you're having diaspora immediately supporting. That has emerged several times in interviews we've had on Sudan. So the localization is a key feature of diaspora work, and that's what enables them to actually access really highly dangerous situations in communities. Now, on the second point on diaspora coordination networks, I also don't think I understood the question sufficiently, but I'll answer to both fronts. In terms of transnational networks, yes. So we are increasingly seeing that diaspora in the UK will collaborate with diaspora in the Australia and diaspora in, for example, the Gulf, and together coordinate their response. So let's say the example of Sudanese diaspora, but we're also increasingly seeing cross-nation diaspora supporting. So when the crisis hit in Sudan, then Syrian diaspora were supporting Sudanese diaspora on how to respond based on their cumulative experiences. So that these transnational networks really emerge. And if we're looking at the Lebanon case study, it's also interesting because Syrian diaspora do a lot of work in Lebanon because of the large presence of Syrian refugee populations. So that transnationality is a really key feature. We weren't able to exploit it as much in our current work, but this would be an avenue for continued research in terms of the transnational benefits and coordination and benefits of diaspora. Now, the second thing is on country level. Yes, again, in the Sudan case study, I'll speak to that because I've been more avidly working on it, but crisis coordination networks have been formed by diaspora, and they comprise often of local actors, mutual aid groups, diaspora themselves, and then international actors. So diaspora sort of like serve as that glue. And this is why we said social capital is really key and a key enabler of diaspora contributions, because they're able to leverage their networks, both professionally and personally, both, family and community ties, but also professional networks and with organizations to mobilize resources, but also to mobilize information. And that becomes a really key resilience capability in crisis settings. I'm going to pause there and thank you.
Thank you, Ella. Halima, I see your hand is up. Over to you.
Yeah, so to add to what Ala just mentioned, for Sierra Leone context, they also have like this organization called TOSHAP. TOSHAP is an established healthcare organization, diaspora organization established in Europe and also in the UK. So they usually collaborate by coordinating, mobilizing resources, and usually come in country to provide support towards the health system. So in terms of transnational, it also occurs for Sierra Leone setting during our findings. Over.
Great. Okay. So I think we've covered a lot, not all of the questions, and some of them I think are resources and also groups that we want to continue to work with as a very useful contribution comment from IOM. Unless Lara wants to jump in, I think it was more of a comment than a question. But from our perspective, this is, as I said, we are very much at the stage now of writing up, of sharing resources. Maybe we can go to the next steps, actually, Ella. Of disseminating. So at the national level, there's quite a lot of interest in this because countries are seeing this as something that can help them. And so we've been trying to join, where possible, fora that are being established or revitalized at the national level, but also globally, of course, we want to get the message out and also promote this as an area for further work. We are interested in having conversations and working with other groups in the area, and the plan is, especially as we think about the policy messages, to come together with some of them, including, we hope, IOM and others working in the field, WHO, other diaspora organizations and so on, to come up with some really important sort of policy relevant messages. And in terms of the research outputs, we are planning to share them through, I mean, we have already published 2, which we'll show you, but also we are planning a special supplement with BMJ Global Health, which will be focused on this specific theme. We'll include more details on each of the countries, will include cross-cutting analysis, and we hope will also include some useful policy messaging. All of that, you know, over the next few months. But also, maybe we just show the next slide, Ala. We have got a couple of papers that have already come out. One is more or less an editorial with BMJ Global Health, and the other one is based on the scoping review. Well, that's been submitted to a special edition that Rebuild is producing, so hopefully will be shareable soon. But all of these resources and the slides will be available on the Rebuild website, which we've put in the chat. We've got a request to present it for the World Congress of Public Health, deadline end of January, so we'll have a look at that. And then I think we've also got some other organizations we can be in touch with in the chat. And we're aware there's a lot of other very interesting country examples. We've been trying to be in touch with other groups working in places like Rwanda and so on, really to collate as much experience as possible in this area. So do stay in touch with us after the meeting if there's any reflections, thought, materials you'd like to share with us, or ways of taking forward, because I think this is not the end of this research strand. It's really just the beginning of flagging it up as a really crucial area for engagement. Any final reflections or comments from the panel? We've got a few minutes left before we wrap up. Anything you haven't said that you really wanted to emphasize?
So maybe I go quickly. So
Please.
Sophia, what I think is, I mean, diaspora community is very much connected with the community back home. For example, in Nepal, like every second house is either connected directly with the diaspora now, or they had the returnee person, I mean, who returned back from the foreign land. So they are basically all over the country. So they have a strength in terms of contributing and reaching to the community. So only, I mean, there should be a motivating factors for them to get connected, and recognition is really needed. And increasingly, I think these fragile setting countries are in a way exporting their health professional now increasingly. I think that creates really scope to better connect with diaspora from the health system lens. Otherwise, it was quite poor in the past. That is how I see from the Nepal's perspective. Probably that applies for other countries as well. Over to you.
Yeah, thank you very much, Ghanshyam. Dr. Al-Sheikh.
Yes, our case study in Sudan has also reflected a unique dimension that diaspora is connecting the international community and connecting people for solidarity. So in terms of leveraging the host country potential, the traditional pathway has been, leveraging governments of host countries and institutions in host countries also to contribute. But what we saw recently in this case study is also leveraging the people in host country, citizens, residents. And in the case of Sudan, we have seen examples of donations coming not only from Sudanese citizens in the host country, but from other nationalities, other people who would like to contribute. So in this case, the diaspora is bridging humanity for solidarity, and this is a new dimension.
Great, thank you very much. Chichu.
Yes, I think I would like to echo again, diaspora contribution is not only towards for us it's a restoration and solidarity of people in rebuilding the country on a humanitarian front. So I think the diaspora contribution is very important, and it's also interconnected between different types of diaspora, not only health, but other diaspora who are not health professionals, really coming together for us, for Myanmar. I think they are coming together in a very systematic formation and giving a lot of contribution toward restoration and towards this humanitarian crisis in Myanmar. So I think they are it is a great time. It is a real time is really needed because the restoration of the humanitarian crisis should be ended. Thank you.
Thank you, Chuchu. So I think we have to bring this panel to an end. As I said, we're certainly not bringing the work to an end. I want to thank you all for your really rich contributions, fascinating insights and reflections, and the work that you're doing in the countries that you come from. And just to say, lots of very nice complimentary remarks about your work in the chat as well. So feeding that back. All to be continued. We look forward to sharing this body of work with everybody, and we will stay in touch as we move forward together. Thank you very much, and thank you for joining us today. And do look at the Rebuild site for any further resources. Bye-bye for now.